Today we are just going to talk about the short stay arthroplasty initiative that we are carrying out in conjunction with Innovus and 360 Medcare. And this initiative is being performed in a public hospital setting. As we are all aware that the pressure on the public health system is significant, especially when trying to get arthroplasty patients through. And one of the major reasons why patients get cancelled is bed block and inability to have post-operative bed. So in Townsville, we have a one public hospital and one private hospital. And I've been doing short stay arthroplasty in the private sector for almost 7-8 years now. And my average length of stay is around 1 to 1.5 days for my hip and knee replacement patients, very close to each other. So we thought we should do that in the public sector. So we enrolled the help of Innovus because they already had a pre-existing patient partner program, which I was using. And in my opinion, it's a priceless addition to the surveillance, management, and rehabilitation for arthroplasty patients. So I'm just going to quickly take you through the journey of the public patients as we do it in Townsville, and I'm going to talk you very briefly through the results. We have over 70 odd patients. So if you look over here at this screen, we can see that there's this journey timeline that we have illustrated on this image, and obviously in this setting, the public patients have to be reviewed by me, the consultant, in my private setting, because the team is a private setting team. So the patient actually comes to me in my private rooms. I consult the patient, I take a history examination, and I determine if they're suitable for hip and knee replacement, and if they're suitable especially for short stay arthroplasty. How short stay arthroplasty is done in Townsville is it's not the same day discharge, it's less than 24-hour discharge. So I do the surgery on a Saturday. I've been given a list on a Saturday where I do 4 patients on, and next day around midday they're all discharged home. So once I've consulted the patient and I'm happy that they are suitable to have short stay arthroplasty, I would refer them to the patient partner, a physiotherapist, who will do a thorough assessment in conjunction with my clinic nurse as well, to look at the comorbidities and assess the patient to make sure that they tick all the social boxes as well, that after the surgery is done, who's going to look after them at home. They've got someone to pick them up, they've got someone to take them home. And to reiterate, the short stay arthroplasty program is a program where they are as much engaged in their treatment as we are providing the treatment to them. So at this level here, where I refer the patient to the 360 physiotherapist, the physiotherapist will go through in detail, step by step at every point of the way, where they're going to have to do certain things and how they're going to be contacted by me or my team or my nurse. But the majority of the contact with the patient is by the patient partner physiotherapist. Once the patient partner physiotherapist has gone through the consultation, my nurse and the physiotherapist will do an OERA score. I'll take you through the next screen where this is a validated score for short stay arthroplasty for patients that have a low risk or a high risk. So we obviously don't want to be starting off a program on high risk patients. So we do the OERA score. Those patients that fit the criteria are put on the short stay arthroplasty list. Once we've done that, then the next one is the preoperative consultation and the education session, which essentially, once again, is me, the physio, and my nurse. We go through and reiterate every step of the way what's going to happen, how it's going to happen. Then we go through the surgical checklist, making sure that the patient is aware. What that involves is that we have given the patient the required amount of information, but also what will be required after surgery. For example, we give them an ice bucket and an ice scarf from our surgery, so that post-operatively they know how to use it, when to use it, and that's a mainstay of the cryotherapy treatment. We also make sure that we're going to be sending them e-scripts for analgesia and rivaroxaban, which is what I use for anticoagulation post-op. So we will send them an e-script 3 days prior to them being admitted, so they can fill the scripts in, and they are fully educated on when to take the medication, how to take the medication, and what the medications are. So that's the preoperative checklist. Then the public hospital contacts them to let them know when they're going to be admitted, and then they show up for surgery on the day they have their surgery. They're admitted in hospital for less than 24 hours, so overnight. No x-rays are done, no bloods are done. All the medication is done through a flow chart. So in hospital, they get the Pentadol, they get regular Panadol, and the next morning they get a rivaroxaban, and they get TXA 1 gram the next morning to control bleeding. And by then, the physio has seen them, get them up, get them home. The physio at the hospital is different to the 360 patient partner of physio. They're employed by the hospital, but they follow a protocol set by me and the patient partner physiotherapist from Innovus. When they are discharged, so they discharge on a Sunday. On Monday morning, the patient partner physiotherapist gets in touch with them, make sure that they're doing well, the procedure went to plan. They reiterates, reassures them everything is okay. Especially people think pain is something going wrong, but that's not the case. It's got to be reassured that pain is normal and how to manage with the pain. So the patient partner usually would say, make sure you ice your knee, make sure you take analgesia when required, pull back on activities if required. So that's day one. Thereafter, the patient is seen in my clinic here at day 10. And at day 10, we do a wound review. The patient partner is in my office with my nurse and myself. We make sure everything's going well, the wound is healing well, the patient's moving well, the family is happy, and they still continue with cryotherapy. And if they require extra scripts, we give them extra scripts for pain relief. Then they're seen again by me at 6 weeks. But in the interim, the patient partner would get in touch with them twice a week for the first 3 weeks and weekly thereafter. If more is required, then the patient partner would see them more regularly. If not, then that's the usual protocol, just to keep in touch and just make sure, reassure the patient that the patient is doing well. So that's essentially the flow chart for what the short stay arthroplasty program looks like. I'm just going to quickly go through the OARA score. The OARA score is basically a score that is used to see if the patient is suitable for ambulatory arthroplasty surgery, and this has obviously come out of the US. And if you look over here, the OARA score is Outpatient Arthroplasty Risk Assessment Score, and it is a web-based score that is a multidisciplinary questionnaire that gives a figure at the end of that. Anything above 60, the patient is high risk. Anything below 60, the patient is low risk, okay? And as you can see in here, the patient is stratified, and this is web-based, and it's easy to access. Most importantly, because it is a validated questionnaire, it gives you legal protection when you have done short stay arthroplasty on a patient, that someone questions you and says, hey, what was the grounds on you doing the short stay arthroplasty, especially in Australia, when we still haven't quite got onto the bandwagon of short stay ambulatory arthroplasty? So this is a good validation questionnaire for us to do. So I've just outlined to you what we have been doing. This program we started in November last year, and so far we've done 78 patients. We've done a bit more, but this is just a result of the 78 patients that we've done. And we've done 41 patients were male, 37 were females. Average age was 64. And here you can see the breakdown from November last year to September now.
So this is the demographics page, and you can see, as mentioned before, 41 males, 37 females, 58 hips, 58 knees, 20 hips. And average length of stay was 23 hours, minimum was 7.5, 2 patients went home the same day, and maximum stay was 54, 1 patient stayed an extra night. The REP score is another score that we take to assess the suitability for joint replacement as a short-stay arthroplasty patients. And the higher the score, the better the outcome for the patient. And you can see most patients were in the higher range. As mentioned before, average length of stay was 23 hours. Now, you can see over here that we did some functional tests to assess the suitability and the outcome. And two tests we did was average sit to stand assessment and average time to up and go assessment. And these tests were done to show that the outcomes are no worse than the patients that are done as inpatients staying in hospital at 3 or 4 days, having inpatient rehab and physiotherapy. So here's the ORA score. As I mentioned, 27 patients were low risk, 2 patients were high risk. We assessed them, we optimized them, and we made sure that they were suitable, and they did very well. We had 1 hospital readmission for pain management, and we had 1 intra-operative surgical complication, and the patient was admitted for a longer period to have the surgery done a few days later. So we had 2 complications in the 78 patients we've talked about, and I think we're going to continue to do this and get more patient outcomes, and we'll present them as a publication in the very near future. I thank you, Novus, for the opportunity to present our short-stay arthroplasty protocols and patient outcomes. Thank you.